There are 4 or 5 syndromes in the renal disease where serum creatinine can rise. There are only four conditions where serum creatinine can rise. That is, patient can have renal failure. And these 4 conditions are acute kidney injury, chronic kidney disease, rapidly progressive glomerulonephritis, and acute nephritic syndrome. There are only 4 conditions in whole of the medicine where serum creatinine rise. That is low GFR, and patient can have one of these 4 syndrome. Regarding acute kidney injury, this is reversible. If this is treated well in time, patient will have complete recovery. Chronic kidney disease, this is very important. Once the patient develops chronic kidney disease means there are no chance of complete recovery, and ultimately patient goes to relentless progression and reach to end-stage renal disease, and ultimately patient will have to be on dialysis or renal transplantation. So that's very important is early diagnosis and early treatment of acute kidney injury and chronic kidney disease, so as to you reduce the progression of chronic kidney disease, or you treat and cure the acute kidney. Third is rapidly progressive glomerulonephritis. This is again very important diagnosis. This is a medical emergency, and this should be diagnosed as soon as possible. Biopsy should be done and treated accordingly with the immunosuppression of plasmapheresis. Otherwise, if you waste time, if time is wasted, the patient will go into chronic kidney disease, and once the patient goes to chronic kidney disease, the patient will have to undergo either renal transplantation or will have to be on the renal replacement therapy in the form of dialysis. So dialysis and renal transplantation, okay, they are available, but reduces longevity and reduces quality of life. Acute nephritic syndrome, again, recoverable. This is well treated in time. This is recoverable. So important in these conditions where kidney can rise. There are 4 conditions. One of the important is acute kidney injury, which is reversible, and all renal failure should be investigated and diagnosed in search of acute insult. And this is the duty of physician, duty of nephrologist to identify the early etiology and treat accordingly. Definitions of AKI, there are many definitions, and basically the acute kidney injury, the deterioration of kidney function, renal function over a period of days. This is called with the resultant retention of nitrogenous waste product. This is called acute kidney injury. And definition wise, serum creatinine, but there are many criteria: Rifle criteria, Akin criteria, and KDIGO criteria. Let us discuss KDIGO criteria. This is most important. Serum creatinine rise more than 3 milligram over 48 hours, and more than GFR for more than 50% in less than 7 days. This is called acute kidney injury. And this is accompanied by low urine output, that is less than 0.5 ml per kg per hour. This is stage 1, stage 2, stage 3 according to the severity of the acute kidney injury. Now, causes of acute kidney injury basically is grouped into three parts: pre-renal causes, renal causes, and post-renal causes. Pre-renal cause and post-renal cause are very important cause. The identification and treatment is very important because most of the pre-renal and post-renal causes are recoverable. Dr. Sunitha ji, welcome. So pre-renal cause and post-renal cause, the early identification and diagnosis is very important because most of these patients are recoverable. Renal cause is a real challenge. So the pre-renal causes mostly they are hemodynamic mediation. Basically, intravascular volume depletion, following excessive vomiting, diarrhea, hemorrhage, trauma. Decreased effective arterial blood volume. There may be patient can be sodium overloaded, patient can be fluid overloaded, patient can have edema, but there is a possibility patient is effectively reduced blood volume or underfilling of the blood circulation. And these conditions are cirrhosis, nephrotic syndrome, cardiogenic shock, sepsis, anaphylaxis. You can remember cirrhosis, nephrotic syndrome patients are edemated. They are volume and sodium loaded, but there is reduced effective arterial blood volume, or you can say underfilling of the circulation, and this underfilling of the circulation will cause acute kidney injury. And the renal cause. Kidney has got 4 components: glomerulus, tubule, interstitium, and blood vessels. So every component's involvement, disease of every component can give rise to kidney injury. The damage to tubule or give rise to acute tubular necrosis. The pathology of glomerulus, glomerulonephritis. Pathology of interstitium, acute intestinal nephritis, and pathology of arterial and venous system will give rise to thrombotic microangiopathy or venous thrombosis. So aggressive and early diagnosis is very important in the management of kidney injury. Post-renal cause always because of obstruction, bilateral ureteric obstruction or lower down bladder neck obstruction. Most common causes are neglected prostate, neglected bilateral ureteric obstruction. They are the most common cause in this region. And obstruction, whenever there is obstruction in the tube in the body, remember one thing: whenever there is obstruction of any tube in the body, will give rise to that organ damage and will give rise to infection. So correction of obstruction and correction of obstruction followed by correction of infection will lead to definitely organ recovery. Now this is now come to the HRS, hemolytic uremic syndrome. The basic pathophysiology, this is the splanchnic circulation. The splanchnic circulation means abdominal organs being supplied by celiac artery, supramesenteric artery, inframesenteric artery, and they all collect blood and go to the portal vein, and ultimately to the inferior vena cava and to the cardiac circulation. So splanchnic circulation is very important because this is a reservoir of the body. Dilatation of the circulation or constriction of the circulation may be responsible for many diseases like shock, like anaphylaxis, like cirrhosis and nephrotic syndrome. And so dilatation of this circulation will give rise to underfilling of this circulation and give rise to reduced effective arterial blood volume. And if it reduced effective arterial blood volume will give rise to an organ injury, and one of the organs is kidney, and this will give rise to acute kidney injury. This is renal circulation. So basic pathophysiology in Hepatorenal Syndrome is splanchnic vasodilatation, approximately 25 to 30%, 40% circulation. Cardiac output goes to the splanchnic circulation. Just remember, if there is dilatation of the splanchnic circulation, a huge amount of the blood will pool up in the splanchnic circulation, and this will reduce the blood to the important organs like kidney and give rise to ischemic injury to the kidney. So in pathophysiology by basic disease, Dr. Shivkumar, welcome. Principal Medical College, Jhansi has come.
Sir,
Come to the front seat, please.
Sir, please.
Shimo Sahib is already waiting for you. So, Shivkumar Sahib, shall I continue? Sir. So this is pathophysiology wise. Basic 2 circulations are involved. One is splanchnic circulation, which is a massive vasodilatation in cirrhosis, followed by the vasoconstriction of renal circulation. So this is basically due to decreased effective arterial blood volume, and this gives rise to vasodilatation and give rise to renal vasoconstriction. So basic pathology, the basic pathophysiology is vasodilatation of splanchnic circulation and vasoconstriction of renal circulation. This is the basic pathophysiology, and so naturally the management and treatment will attack on these systems. Pathophysiology by functional renal failure. This is not a structural renal failure. Functional renal failure means if these HRS patient, if kidney of this patient is transplanted into another patient, will start functioning. So this is not a structural kidney disease. This is a functional renal failure, and this does not denote the structural damage to the kidney. In fact, this denotes the patient has got severe advanced liver failure. If you correct the liver failure, if you correct the liver pathology, the kidney function will improve. So pathophysiology by HRS is a functional renal failure. There is no structural damage. Portal in cirrhosis, there is portal hypertension. This causes splanchnic vasodilatation. This reduces effective arterial blood volume, and this ultimately causes renal vasoconstriction. So underfilling of the circulation This leads to RAS activation, and sympathetic nervous system activation. Both RAS activation and sympathetic nervous system activation give rise to renal vasoconstriction, and renal vasoconstriction ultimately give rise to functional renal failure. So this is equivalent to pre-renal kidney disease. So pre-renal kidney disease or functional renal failure or HRS, they are same. They are same. So diagnostic criteria of hepatorenal syndrome is very important. Once the patient have advanced liver disease, either in the form of cirrhosis with ascites, decompensated cirrhosis. Decompensated means patient has cirrhosis, with patient has got ascites as well. This is called decompensation. So decompensated cirrhosis, acute permanent hepatic failure, diffuse metastatic liver disease, they are all the advanced liver disease, and this will all they can all have a potential to cause hepatorenal syndrome. Serum creatinine more than 1.5. No improvement in serum creatinine after at least, usually cirrhotic patients are on diuretic and many other drugs. And patient is developing rising serum creatinine more than 1.5. You stop diuretic, you give intravenous albumin, and the patient does not respond with diuretic withdrawal and by albumin injection. Albumin is given a very high dose, 1 gram per kg per day to the tune of 100 gram per day. If the patient does not respond, creatinine does not respond to diuretic withdrawal and albumin infusion, this means the patient has got established hepatorenal syndrome. And once the hepatorenal syndrome is established, there are some drugs are available, but the most important treatment is recovery of renal function. Either with the help of drug, the liver functions are improved, or patient have to undergo liver transplantation. So, before you diagnose HRS, the patient should not have shock, no current or nephrotoxic drugs. Nephrotoxic drugs are ascites, aminoglycoside, radiocontrast. There should not evidence of intrinsic kidney disease. That is, when you diagnose HRS, patient should not have a proteinuria that is less than 500 milligram per day. Patient should not have RBC in the urine. Normal ultrasound kidney size. Normal kidney size is 9 to 12 centimeter. Less than 9 centimeter is small kidney. So the causes of HRS occur in severe liver condition that produce portal vein hypertension and marked circulatory dysfunction. HRS occurs in advanced cirrhosis with portal hypertension, acute liver failure, severe alcoholic hepatitis, acute or chronic liver failure, advanced metastatic liver disease, hepatic vascular disorder, that is Hepatorenal syndrome, with severe portal vein thrombosis. So they are the causes of HRS. So precipitating of HRS, because HRS is a bad diagnosis. There are two types of HRS, we'll come to later. So before you diagnose HRS, you should have removed the other causes of acute kidney injury in the liver setting, and you should treat and identify the precipitating factors for HRS, like SBP. SBP is spontaneous bacterial peritonitis, GI bleed, overdiuresis, large volume paracentesis without albumin. Approximately 1 liter of ascites is tagged with 10 gram of albumin. So whenever cirrhotic patient is done paracentesis, this should always covered by with intravenous albumin. If you don't give intravenous albumin and do paracentesis, patient will precipitate HRS, or patient may go into hepatic encephalopathy. Now treatment of HRS. Stop aminoglycosides and contrast. If patient is planned for the contrast, do not give contrast. Treat precipitating factors, correct hypovolemia, manage GI bleed, manage SBP, intravenous albumin 1 gram per kg per day, maximum 100 gram on day 1, and then 20 to 40 gram per day. Vasoconstrictive therapy, terlipressin is the best drug. Terlipressin and albumin is the first choice. It should be given for 14 days. If the patient does not respond within 14 days, then things will go downhill. If the terlipressin is not available, you can give NORAD infusion in the ICU setting. You can give midodrine octreotide in the ward setting. The role of renal replacement therapy, that is dialysis. Dialysis usually will not give any benefit to the HRS, but dialysis is indicated when the patient has got hyperkalemia and patient has got severe metabolic acidosis and patient has got uremic complications. And definitive treatment is liver transplant. So this is all about HRS. Thank you very much.
That's a wonderful lecture by Dr. Sengar. Now,
What is the difference in urine examination in these patients with the normal pre-renal and renal patients with HRS? Because basically this is treated as a pre-renal failure with treatment of the cause of the liver disease. So is there any difference?
As I said, pre-renal AKI and this is HRS, the same as they have got same thing. Urine won't be any difference. But urine examination is very important. If patient has got proteinuria, if the patient goes microscopic hematuria, then this is unlikely to have Hepatorenal Syndrome. The differentiation between clinical differentiation and therapeutic differentiation is pre-renal AKI. If you correct the pre-renal condition like hypovolemia, patient will immediately improve. In HRS, with the correction of hypovolemia only, patient does not improve. You have to go for the vasoconstrictive therapy plus albumin for 14 days before you declare patient will improve or patient will not improve.
Is there any role of renal liver transplantation in acute setting like HRS in tertiary care centers where facilities are available?
See, HRS always occur in advanced liver disease, be it acute or be it acute or chronic or be it chronic liver disease. So obviously, if the patient acute liver condition does not improve, obviously patient will have to undergo liver transplantation. Yes.
Have you been able to save?
In type 2 HRS, I can remember, I predicted many of the patients having creatinine 1.7, 1.6 1 year before. After 1 year, your function will improve, and so few patients died and few patients underwent hepatic transplantation.
It is a very bad problem.
It's a bad problem. So remember, serum creatinine 1.5 looks very, very small. It's a very small thing. If a patient had got cirrhosis, alcoholic cirrhosis, ascites and creatinine 1.5, and there is no other precipitating factors, this is HRS, and this will definitely worsen in the near future. HRS median survival is 6 months. 30% survival till 1 year. So before you reach to this stage, should go for liver transplantation. Liver transplantation is the only and definitive treatment.
Dr. Rambabu, have you been able to save anyone?
And there is set diagnostic and treatment guidelines are covered. So many patients are now recovered.
Actually, intravenous albumin are freely available in our medical college. Asad Rog Nidhi.
Okay, 10 years back.
If you don't give albumin in terminal patient,
Previously, the limitation is the serum albumin level. Most of the time, albumin is not available or not affordable. So that's why we cannot raise the blood pressure of the patient. So my query is, sir, as you save the nephrology in our city and you teach all of us in nephrology cases. My query is that, as you say that before diagnosing HRS, we should rule out all the risk factors. So many risk factors. But I would like to emphasize one risk factor, that is hypovolemic state. Hypovolemic state.
Exactly.
It's very important. Patients come with ascites. So how we detect, how we suspect that patients and how we manage, how we raise the hypovolemic, because patient already in hypoalbuminia and decreased renal perfusion.
Yes.
So how we detect these?
Cirrhosis patient has got massive ascites, edema. This is edema and ascites means patient is already fluid overloaded and sodium loaded. But fluid is not in the circulation, fluid is outside the circulation. Patient जो weight उसका 50 किलो होता 70 किलो वजन है, लेकिन effective arterial blood volume कम है, because the fluid is lying outside the circulation. Definitely there is one machine, body composition meter will not detect it, because that will show the whole body water, whole body sodium. So this is a clinical judgment. Clinical patient has got ascites, patient, and look for no other precipitating factors. Patient must not have taken NSAIDs, aminonuclear acids, contrast, sepsis, SBP, UTI, cellulitis. If a patient does not have all these conditions, this means this is HRS. HRS basic pathophysiology is decreased effective arterial blood volume with renal vasoconstriction. And you have to correct this pathophysiology by giving volume expander. And volume expander of drug of choice is albumin. Albumin is given 20 kitna? 20 gram, 1 gram, 5. 5 bottles on day 1, then 3 bottles for 14 days. So it's very expensive. And terlipressin 1 milligram 6 hourly to 2 milligram 6 hourly for 14 days. If the patient of HRS may improve, may not improve. If improve, okay, you can have 6 or 7 months more. Other does not improve, go for liver transplantation.
So I will use serum sodium level
Hyponatremia. Yes.
sodium levels.
Similarly, in this condition, as well as in liver failure, heart failure, I have volume dilution. Because of volume dilution, hyponatremia. So dilution or hyponatremia. So hyponatremia is another marker for severity of the liver disease or severity of the heart failure.
Yes, sir, very nice talk. I'm Dr. Namdev from HRS itself is an indication for transplant, and it is, as very well said, it is of 2 types. And as it is said, it is very grievous condition, but HRS patient should not die, ideally. So type 1 will always have a precipitating factor, and that should be treated first of all. So it is reversible. Actually, HRS type 1 itself by definition is reversible condition, because if you treat the precipitating factor, patient should be saved and sent to transplant maybe after some time. Now HRS type 2 is a physiological change where there is no precipitating factor, and patient, because of liver disease, as sir has rightly said, this kidney is normal, which even after the death of the patient can be transplanted. So because of the liver disease progression, HRS type 2 is that refractory ascites, and then renal decompensation occurs and patient dies of it. So HRS type 2 becomes a absolute indication for transplant. So basically HRS itself, patient should not die, it has to be saved. You have to treat the precipitating factor. Albumin and terlipressin is life-saving, and doses, actually it is like that, but if you give even in the lower doses, it can be saved. And for transplant, sodium is a very important criteria. So that criteria goes with MELD. Now it has been redefined as MELD NA. So sodium itself in these patients is on lower side. So that should not be tried to be corrected, because that will definitely increase the ascites. So the level of sodium is by physiology is on lower side, but MELD NA, which is very well available on internet, should be calculated for these patients, and then they should be actually listed for transplants. So HRS type 1 for me is not a condition where patient should die. So there is a difference of opinion that HRS type 1 should be saved. HRS type 2 gives you enough time so that patient can be referred for a transplant.
Exactly. So HRS type 1 is and the patient should be saved. Then you have a 4 or 5 months time for liver transplantation, and definitely treatment is liver transplantation.
Sir, in patient of ascites, maybe because of CLD, maybe because of kidney disease or CHF, in our armamentarium to reduce water load is diuretic, and it is a double SO. Once we start diuretic, it keep increasing. So what is your take on how should we proceed these patients?
Good. Diuretic does renal damage. In context of renal problem, diuretic does 2 things. One is volume depletion, because of volume depletion can give rise to further hemodynamic compromise and give rise to acute tubular necrosis or subacute tubular necrosis type of thing. Number 2 is the on continuous diuretic patient can also have acute interstitial nephritis. So in the clinical presentation of both will be different. In acute interstitial nephritis, patient will not be hypertensive, patient will not be overloaded, but there will be rising of serum creatinine, decrease of urine output, and the presence of eosinophil in the urine, presence of RBC in the urine, and serum creatinine will rise. So in those conditions, withdraw if diuretic is found to be responsible for, this is your clinical suspicion. And clinical suspicion of acute interstitial nephritis will be confirmed only by biopsy. So if you don't have any other thing like sepsis, other drugs, you can withdraw the diuretic and see the clinical response. So diuretic does need to acute nephritis. So far in my clinical practice, it's not very common. It's not very common. But cirrhotic patients who are on an excessive diuretic, you want excessive diuretic, then patient can have further reduce the effective artery blood volume, and this effective arterial blood volume can be filled by albumin or by radiation diuretic, and sometimes by filling the circulation with albumin, diuretic response will improve.
So in initial days, we are very happy. Once we start diuretic, patient has more diuresis, abdominal edema comes down. But on the third day,
critically ill, patient are lying down in bedridden. So look for further causes of renal deterioration. One is sepsis, and patient in supine position will sometimes give rise to back muscle ischemia, and back muscle ischemia because of back muscle pressure give rise to sort of rhabdomyolysis, and this release of CPK and myoglobin can give rise to further renal injury. So bedridden things should be avoided. That's why Dr. Praveen Kumar Jain used to always say, mobilize the patient, mobilize the patient. So mobilization and physiotherapy is very, very important. It's a very good adjunctive therapy for everything.
So as we comes to an end, and we would like to participate.
And thank you, Jaskaran. You have used so nice word for me. I salute you. Thank you very much.